presentations and Q&A section of our early triple-negative breast cancer poster spotlight. I'm Hope Rugo from the University of California, San Francisco, and I have two fabulous discussants, Filipa Lynce from Dana-Farber Cancer Institute in Boston, and Rita Nanda from the University of Chicago in Chicago. And we have great posters here, which hopefully you've had a chance to see, to discuss about early triple-negative breast cancer. Now, we're going to have our poster presenters come up to the stage now as we get started. So we want Isobelle Wall to come up, Pooja Advani, Hans Christian Kohlberg, Vera Gertz, and Dr. Im to come up to the stage. And Filipa will take over.
Thank you.
Okay, we got everybody.
Great. And I think that this is to advance the slides. Okay. Hi, everyone. Good afternoon. I'd like to start by thanking the organizers for the opportunity to discuss some of the posters that were selected for this session. Here are my disclosures. These are the abstracts that I'll be discussing over the next 15 minutes. These abstracts cover predictive factors of response to therapy in early-stage triple-negative breast cancer, predictive factors for response to immunotherapy in metastatic triple-negative breast cancer, and finally, we will look at differences between metaplastic and invasive ductal triple-negative breast cancer. So neoadjuvant chemoimmunotherapy is the preferred treatment approach for patients with clinical stage 2-3 triple-negative breast cancer. We all saw the results of KEYNOTE-522. In this trial, neoadjuvant pembrolizumab plus chemotherapy followed by adjuvant pembrolizumab resulted in a significant improvement in event-free survival and overall survival when compared to neoadjuvant chemotherapy alone in patients with high-risk early-stage triple-negative breast cancer. As expected, the use of chemoimmunotherapy was associated with an increased risk of immune-mediated adverse events. A question that remains to be answered, and a broad question that I don't think that we'll be able to answer today, but it's whether can we identify tumors that are unlikely to benefit from a chemoimmunotherapy approach, therefore sparing patients from immune-related toxicities. So let's start looking at some of the posters that are being presented today. In this first poster, Dr. Kohlberg and colleagues conducted a subgroup analysis of the neoadjuvant NEO-MONO trial. So NEO-MONO is a phase 2 randomized multi-center trial that enrolled patients with early-stage triple-negative breast cancer to receive neoadjuvant atezolizumab with chemotherapy. If you see in arm A, these patients received 1 dose of atezolizumab 2 weeks prior to starting combination treatments. The primary endpoint of this study was PCR, and the results that were quite impressive were presented at San Antonio last year. The goal of this subgroup analysis that we are seeing today was to look at patients with high-risk triple-negative breast cancer defined as a tumor size of at least 2 centimeters and/or lymph node involvements. So in this subgroup analysis, as expected, we can see that patients with PD-L1 positive disease experience higher PCR rates, which had been shown in the overall population and has been shown in other studies. But however, it doesn't seem that the addition of a run-in with atezolizumab led to a significant improvement in PCR rates, and this was also shown in the overall cohort. On multivariate analysis that you can see on your right, and this analysis included the arm treatment assigns, PD-L1 status, tumor and nodal staging, tumor grade and age. Only PD-L1 status and grade 3 were significantly associated with PCR. So the authors concluded that in this analysis of the NEO-MONO trial, the association between PD-L1 status and PCR rates demonstrated in the ITT population were reproduced in a subgroup of patients with higher risk disease, which is in line with exploratory results of the NEO-TRIP and the IMpassion031 trial that we've seen before. So a few questions I have for the authors that perhaps we can discuss during the Q&A is, do you feel that this question of induction with immunotherapy prior to combination is finally addressed and closed, or do we need other studies? And do you anticipate that the PD-L1 status will be associated with long-term outcomes with atezolizumab, and similar results will be presented in terms of Keynote 522 results? So another important question is whether we can identify predictive factors for response to neoadjuvant chemotherapy in high-risk early-stage triple-negative breast cancer. So in this study, led by Dr. Wall and colleagues, 85 core biopsies were collected prior to neoadjuvant chemotherapy treatments. Patients were classified as responders or non-responders, and for those that were non-responders, post-treatment surgical resections were collected as well. Each tissue section was H&E stained, imaged, and annotated by a pathologist, and GeoMX digital spatial profiler was used for spatial transcriptomics. So tissue sections were stained with fluorescence antibodies against PAN-CK and CD45. From the PAN-CK positive regions, 7 transcriptionally distinct epithelial states were defined by performing hierarchical clustering on pathway signature scores. Gene set enrichment analysis was performed to define the molecular functions of each epithelial state, and I don't show you that data here, you can see more in the poster. And the linear regression model was used to assess their association with responses to neoadjuvant chemotherapy. The authors found that 2 epithelial states, ES2 and ES4, were found to be associated with responses to neoadjuvant chemotherapy. In terms of the CD45 positive compartments, 7 distinct tumor immunomicroenvironments were obtained and were characterized according to different proportions of immune cells. Here as well, a linear regression model was used to assess the association of each time with responses to neoadjuvant chemotherapy. The authors found that time 1 and time 5 were associated with responses to neoadjuvant chemotherapy, and they also identified combinations of epithelial states and times that were unique to responders or non-responders, and that's what you can see on the right of these slides. So the authors concluded that in one of the largest spatial transcriptomics data sets presented with detailed histological annotations, the abundance of epithelial states and tumor immune microenvironments was predictive of PCR following neoadjuvant chemotherapy in patients with early-stage triple-negative breast cancer. So I listed here some questions for the authors. Given the inherent heterogeneity of the disease, how well do you feel that the core biopsies from baseline represent the whole tumor? I would like to know as well in which of these analyses the surgical specimens were included, and did you see any changes in the pre- and post-treatment specimens of non-responders? And how do you envision that this type of data can be incorporated into clinical practice and clinical decisions? So another important question is whether we can identify predictive factors for response to post-neoadjuvant immunotherapy in early-stage triple-negative breast cancer. Is there any factor that can help us decide what to do for those patients that have residual disease? So Dr. Im and colleagues conducted a genomic and transcriptomic analysis of residual tumors of patients who participated in the MIRINE trial. So this trial is a randomized phase 2, multi-center, open-label trial of atezolizumab and capecitabine compared with capecitabine alone in patients with triple-negative breast cancer who had residual disease after neoadjuvant chemotherapy. The primary endpoint for this main study is 3 years invasive disease-free survival. The last patient was enrolled in June 2023, and data are expected during 2025 or 2026. So the study being presented here today, after all patients completed enrollment, aims to characterize residual triple-negative breast cancer following neoadjuvant chemotherapy. You can see on the right the type of analysis that was conducted in these specimens, and these included evaluation of stromal TILs, targeted DNA sequencing, RNA sequencing-based molecular subtyping, and immune cell deconvolution. So here is the first set of results. Through targeted DNA sequencing, the authors found that pathogenic alterations in the PI3K-AKT pathway were observed in about 28% of the patients. And again, this is all residual tumors. And and homologous recombination repair-related genes were mutated in about 12% of the patients. The authors also showed us that the distribution of molecular subtypes varies relative to TIL infiltration levels. For example, if you look at the TIL high group that is on the right side of each of these graphs, the TIL high group was enriched for basal-like immune-activated and TME subtypes immune-enriched and immune-enriched fibrotic, while the TIL low group, here defined as less than 30%, was enriched for basal-like immune-suppressed and TME subtype immune-depleted and fibrotic. So in conclusion, residual invasive triple-negative breast cancer after standard neoadjuvant chemotherapy in the MIRINE trial were predominantly mesenchymal, basal-like immune-suppressed, followed by basal-like immune-activated subtype, with a high frequency of p53 mutations, and TIL-high tumors were associated with an immune-enriched cancer type, including basal-like immune-activated and specific TME subtypes. So my questions for the authors are, were you able to collect core biopsies prior to starting neoadjuvant chemotherapy? And if so, how is the distribution of subtypes and TILs different from the initial tumor? And I'll be curious to see the clinical outcomes results and see how these subtypes correlate with clinical outcomes and response to each of these arms. So the next question is whether we can find factors predictive of acquired resistance to immune checkpoint inhibitors in triple-negative breast cancer in the metastatic setting, and can that help us distinguish those with primary resistance to those that have acquired resistance to treatments. So in this study, Dr. Gertz and colleagues aim to provide an in-depth analysis of the clinical features, immune and genetic landscape of patients with metastatic triple-negative breast cancer who participated in TONIC-1 and TONIC-2 and who develop acquired resistance to immune checkpoints blockades. As a reminder, you see here the design of the TONIC trial. Patients with metastatic triple-negative breast cancer were randomized to receive nivolumab without any induction, or one of 4 immune induction treatments that could include radiation, cisplatin, doxorubicin, or cyclophosphamide, followed by nivolumab. We all have seen the results of the first stage of the trial that were published in Nature Medicine. The study found that doxorubicin and cisplatin may induce a more favorable tumor microenvironment. Therefore, the doxorubicin cohort was expanded in the second stage of the TONIC trial, and the cisplatin cohort is further expanded in the TONIC-2 trial. So for this analysis, the authors defined acquired resistance as patients who progressed followed an initial response with a PFS of 6 or more months, and had at least a follow-up of 1 year. You can see in this table that patients with acquired resistance had higher TILs than those with primary resistance to treatments. In this study, as a reminder, biopsies were taken at baseline after 3 cycles of nivolumab and at time of progression. The tumor, what the authors showed us here, they wanted to show us changes in the tumor microenvironment over time, and what they showed was that compared to the features at progression compared to at time of ongoing response, showed a decrease T-cell receptor beta clonality, MH2, and co-activation molecules. I thought that this was interesting as well, and although the sample size is small, the authors reported that the patients with acquired resistance and oligoprogressive disease had a similar overall survival of those with durable response, which is illustrated here in these Kaplan-Meier curves. So to conclude, patients with acquired resistance had a more favorable tumor microenvironments at baseline compared to patients with primary resistance to checkpoint inhibition as monotherapy, most of the time on treatment. Signs of hampered antigen presentation and decreased T-cell activity at time of acquired resistance were observed, and patients with acquired resistance and only oligoprogression seem to have similar overall survival as patients with durable response, although this was an N of 4 only. So here are some questions for the authors. Did the authors evaluate heterogeneity of the tumor microenvironments within the same tumor? Can the increase and then drop in TCR clonality be a reflection of increase followed by decrease in T cells? Did the authors look at BCR? How were patients with oligoprogression disease treated? And how do you envision that these findings may inform novel approaches for overcoming acquired resistance to immune checkpoint blockades? So to finalize, the last poster looked at differences between metaplastic triple-negative and invasive ductal triple-negative breast cancer. This was addressed by Dr. Advani and colleagues. They looked at 364 patients with invasive ductal triple-negative breast cancer and 91 patients with metaplastic triple-negative breast cancer. These tumors were analyzed by next gene sequencing and whole transcriptome sequencing by Caris Life Sciences. And you can see here on the right that they found that metaplastic cancers had higher frequency of PIK3CA, EGFR, TERTs, and lower frequency of P53, just to name a few. In terms of immune cell infiltrations, they also found differences. Metaplastic breast cancer had increased infiltration of M2 macrophages and neutrophils, but decreased infiltration of B cells, Treg, dendritic cells, and CD8 T cells. They also found that metaplastic had higher expression of stem cell-related genes. And just I thought that it was interesting just to remind everyone about the results of the SWOG-S1609. This trial looked at dual anti-CTLA-4 and anti-PD-1 blockade in rare tumors. I show you here the results of the cohort that focused on metaplastic breast cancer, which for an aggressive disease, many of these patients were heavily pretreated. An objective response rate of 18% is nothing to ignore. So to finalize, I will just go straight to the questions for the patients. I wanted to the authors, I wanted to ask whether the different histological subtypes of metaplastic breast cancer were taken into consideration, given that literature suggests that genetic heterogeneity in metaplastic carcinomas correlate with histology. And based on these data, what do the authors envision as the next step to improve outcomes of patients with metaplastic breast cancer? So I would like to thank all the patients, all the authors, and my colleagues for their thoughts and invaluable discussions.
Thanks. Thank you, Mayo. Okay, great. So we're now open for questions, so please come up to the microphone if you have a question. I'm going to start by asking a question while I look for anybody who's going to come up. That's, I think, okay. So for Dr. Kohlberg, one of the questions was, should we investigate lead-ins further? And I guess for the mono trial also, Dr. Im, it would be helpful to just, between the two of you, think about, should we still be exploring a way of trying to, do an induction? And the same is true for Dr. Gertz for the tonic trials. Like, what should we do next? Because now we've investigated in several ways. Say who you are. You don't have to hit it, it's just on.
Okay, it just starts, okay. I'm absolutely sure that we should go on investigating how to make tumors more immunogenic, and that it's definitely important to do window trials in that situation. Probably the 2-week window is not the right way to go, because we saw actually in no analysis we saw any treatment interaction. And we have a trial without chemo arms, so we should have seen a difference. I strongly believe that we should go on that way, but not with that arm. So we will go on with biomarker analysis rather.
So how do you mean biomarker?
No, what I say, we will not go on with a second trial about that. We will use our population with more than 1,000 specimens to identify predictive biomarkers. Yeah.
Which is excellent.
Maybe, yeah, I can add to that. So we're of course looking at the metastatic setting, and indeed we saw that a short induction treatment of 2 weeks does something on the tumor microenvironment, although the changes are subtle. So I agree with my colleague next to me that might this 2 weeks indeed do something to your tumor microenvironment to make it more inflamed, but that 2 weeks might not be sufficient, especially not in a metastatic setting, because what we see is that those tumor microenvironments are really immune depleted, especially in those heavily pretreated patients. So the 2 weeks, the induction idea I think is good, but might need a bigger bang there.
Now, one wonders if you should do it in the first-line metastatic setting. Maybe the immune system is more intact. I mean, we see less immune toxicity in the metastatic setting too, and I don't know that you can recover it when the tumor burden is high. That's, I think, the big question.
So, although our Mirena clinical trial is not using the neoadjuvant immune checkpoint in neoadjuvant period, we only use the immune checkpoint in adjuvant period, which is very different with other clinical trial. But we do have another clinical trial we're presenting tomorrow. We use the one time of durvalumab induction before standard of neoadjuvant chemotherapy. It makes more immunogenic after if you compare the baseline and on-treatment biopsy, you can see the increased CD8 positive cytotoxic T cell and immune microenvironment will be changing. So we will talk about that tomorrow for the poster.
That's a poster?
Poster
tomorrow?
Highlight.
Great. So it sounds to me like the sort of summary of that is that there may be some value to doing an induction in the right setting. That 2 weeks isn't enough, and maybe if you had already identified the people who have an active immune microenvironment with, we have a variety of now gene expression panels looking at immune positive tumors, and you separated out those patients, we might have a better idea of how to stimulate the immune microenvironment in the patients who don't have that immune signature. I don't know if there's any work going on in that. In I-SPY, we're certainly looking at that idea, but still working on it, the idea of what to do with those tumors. And then let's see, so we talked about tonic. What? Oh, do we have a question? You're very far away. I have to put on my glasses to see you.
I think it's to discourage us. The microphones are right at the very edges of the room.
I know. You have to come into the center.
I've trekked from San Antonio over to Greenland over here to ask. Andrew Tutt, ICR London and King's College London. Fantastic session, thank you. It's a question to Dr. Im. You report roughly 12% of the patients in the trial had mutations.
I think, you're actually kind of hard to hear up here. I'm not sure exactly why, but so just, yeah. Speak louder.
Let me try again.
Perfect.
Is that better?
Yes.
Okay. Andrew Tutt, London. Question to Dr. Im. You note that roughly 11 or 12% of the patients had mutations in HR-related genes. Often in triple-negative breast cancer, there's a wider group of patients who have homologous recombination defects due to epigenetic suppression of BRCA1 and RAD51C. Have you measured that at all in your trial, and have you been able to look to see in the residual disease whether or not there's reversal of that methylation or reversion mutations in the BRCA genes?
Thank you for the question. At this time point, we did not see the methylation or reversion of the BRCA mutation in our cohort. If we have data and we have a tumor, so it may be a good thing to collaborate with regarding the methylation and reversion. So the percent of the HRR mutation and BRCA mutation in our population is very consistent with metastatic breast cancer who were in the Olympia trial and our Olympia trial.
Thank you.
And then let's see. So for Dr. Advani, should we be treating the metaplastic cancer, this is from the online, as sarcoma with regimens like AIM and combined with immunotherapy? And in fact, my question was, what's next for metaplastic disease? Because this is such a difficult clinical question now.
Yeah, absolutely. So I think what we saw in our data is that, there was no statistically significant difference between the PD-L1 by 22C3 between metaplastic and invasive ductal triple negative, albeit the percentage positivity rate was about 50%. So I think that that's really provocative to continue to justify exploring immune checkpoint inhibitors. And as Filipa showed, the DART trial, and there are several case studies that have showed not only responses, but durability of responses. But I think simultaneously, we want to probe into strategies to negate the immunosuppressive tumor microenvironment. Although it was a deconvolution of whole transcriptome analysis and not direct immunohistochemistry, we can see that there is an enrichment of M2 macrophages and neutrophils and other immunosuppressive types. And in our lab, we're now doing single-cell transcriptomic analysis specifically on metaplastic to determine the different WHO subtypes, how do they respond, or what is their tumor microenvironment. So I think that it probably would involve a combination strategies of PD-1 inhibition, but also some ways to decrease the immunosuppressive tumor microenvironment.
So you wouldn't at present recommend just abandoning the idea that it's a breast cancer and treating like a sarcoma?
It's obviously a hard question, but I think that I would still continue to explore, sarcoma-like regimens for the right subtype. So I think that spindle cell tends to behave a little bit more like sarcoma. We've also seen some data that it is also enriched for PD-L1 expression, up to 50 to 60%. So I think that that is a viable strategy, to treat it like a sarcoma, but I wouldn't sort of think that every different subtype of metaplastic would respond just like a sarcoma would.
Thanks. And then Dr. Wall. There you are. So you looked at neoadjuvant chemotherapy, but not immunotherapy, right?
Yes, mostly looking at ECT with or without carboplatin.
What?
Mostly looking at ECT treated with or without carboplatin. Yeah.
And how do you expect immunotherapy, which now, of course, is standard in early triple-negative breast cancer in the neoadjuvant setting, to, as we heard, to impact your results? I mean, can we use that kind of results to understand who would benefit more from immunotherapy or less?
Sure, I think that we sort of already touched on it a little bit. I think the key is going to be understanding what the epithelial states, as we've sort of looked at, are within a given tumor and the particular immune niches that are sort of co-occurring with them. And then how do we use perhaps chemotherapy induction or immunotherapies to then induce specific epithelial states that are more or less responsive to chemotherapy, and then of course we can extend that to immunotherapies as well.
That's great. And let's see, did you have any questions for the group?
I had many.
Oh, you did? You could ask one.
Oh, gosh.
But I think
Anyone feel strongly about answer any of the questions that I listed?
Yes.
Perfect.
Okay, we can have one answer. You have to be quick.
Just briefly about PD-L1 as a biomarker. We had 90% almost 90% PCR rate in the PD-L1 positive group. Yesterday we had a low-risk paper with smaller tumors, not negative, 100% PCR rate as a poster. So I truly believe that this paradigm that the PD-L1 is not really an influential biomarker in immunotherapy is not correct. It depends on what you look at. So what we will do with our population is look at other biomarkers, but I think PD-L1 should definitely be seen as, especially in low-risk population where you would normally not give immune therapy, as a possibility to really select who would maybe benefit. Yes.
Although the low-risk population has a very high response to chemotherapy, even without immunotherapy, and PD-L1 predicts response to chemotherapy.
Yeah, we only had 58% in the immune therapy chemotherapy arm if the patients were PD-L1 negative, and 100% in the low risk if they were PD-L1 positive. That's 40% difference.
Big difference. Well, thank you very much to all of the poster presenters and to our excellent discussant. And now we're going to have our next discussant, Rita Nanda, come up, and then Dr. Strahan, Hackbart, Anampa, Polho, Espinal.
I can see these slides down here. I'm too short. I want to tie it all together.
Here, this is where you look.
Yeah.
If you want.
Yeah. Is it okay if I turn that on? I'm blind. I use new contact lenses.
And apparently deaf too. A lot of them, no, but I don't think anybody can hear. I always asked her.
Yeah.
All right. Okay.
All right. Thanks to everyone for sticking around so late. If I weren't speaking, I'd probably be in bed by now. Here are my disclosures. And as you heard from Dr. Lynce, the Keynote 522 regimen is now the current standard of care for patients with stage 2 and 3 triple-negative breast cancer. We've seen data now that there is a significant improvement in PCR, event-free survival, and at ESMO this year, we saw a significant improvement in overall survival. So really exciting to see. But there remain a number of unanswered questions in the management of patients with early-stage triple-negative breast cancer. I'd like to thank the poster presenters here for addressing some of these questions, or at least starting to. In terms of thinking about the optimal therapy for residual disease, and I think this is an evolving area, we've had capecitabine that we've been using for many years now based on the CREATE-X clinical trial, and it has really been established as a standard in that space. However, after neoadjuvant chemotherapy, not any data with immunotherapy yet, but I think many of us extrapolate and do use capecitabine in that setting. So we'll review a real-world capecitabine use in patients who've received neoadjuvant chemotherapy alone for early stage 2 and 3 triple-negative breast cancer. And then we'll cover a few abstracts that are looking at how to manage patients with small triple-negative breast cancers, you know, the T1A to T1C. And we've got two really nice complementary abstracts here that we'll review. And then predictive biomarkers of chemotherapy response. I mean, obviously, there's not anything we really use in that setting, but I think some interesting data looking at the neutrophil to lymphocyte ratio from our colleagues in Brazil and how that correlates with response to neoadjuvant chemotherapy, and then the impact of antibiotics on immunotherapy efficacy in patients who have been treated with the Keynote 522 trial, a small cohort study from a single institution, but I think in line with what we're seeing from other data. So I think, again, really great abstracts, and it's my pleasure to discuss them. So as you'll all recall, the CREATE-X trial, which was published back in 2017, showed us that 6 to 8 cycles of capecitabine given in the adjuvant setting for patients who've received neoadjuvant chemotherapy alone for triple-negative breast cancer was associated with a significant improvement in disease-free survival as well as overall survival. And so, again, I think it has become a standard for our patients who have residual disease after neoadjuvant chemotherapy. And again, we're using it in the post-Keynote 522 era as well except for those patients who harbor germline alterations in BRCA1 and 2, where I think many of us think about using PARP inhibitors in that setting. So the first abstract was looking at real-world data of capecitabine utilization and outcomes in patients with residual disease after neoadjuvant chemotherapy. And so this was a study in almost 1,000 patients who were treated at 3 institutions, The Ohio State University, Dana-Farber, as well as MD Anderson. And these patients were treated over the course of 3 years from 2016 to 2019, so before we routinely started incorporating neoadjuvant immunotherapy into the mix. So these were not patients who'd received immunotherapy, just chemotherapy. And what was seen here was that adjuvant capecitabine in patients who had residual disease was associated, just like we saw in the CREATE-X trial, with improvements in recurrence-free survival, distant recurrence-free survival, as well as overall survival. So really giving us a reassurance that these data in the real-world setting are relevant. The utilization, however, interestingly, was about 30%. It did increase over time from 2016, obviously with the publication of the data, to 2019, but only about a third of patients who were eligible for capecitabine actually received it. So I think that's interesting to point out. And also, obviously, we don't have data about capecitabine and adding it to adjuvant pembrolizumab for patients who have residual disease. So I'm hoping that'll be the next step here and that we'll get some data there. So I think that would be interesting to see. As you know, what we do with patients who have triple-negative breast cancer and residual disease after neoadjuvant chemoimmunotherapy is evolving. We have 2 large randomized phase 3 trials and a whole host of other trials looking at antibody-drug conjugates in this space. So the OPTIMIZE-RD trial is looking at adding sacituzumab to adjuvant pembrolizumab versus physician's choice therapy, be it continuing pembro, adding CAPE, or doing observation, whatever the physician hopes to do. And here is looking at 8 cycles of adjuvant sacituzumab. The TROPION-Breast03 trial has a really interesting design that I'm pretty excited about, looking at Dato-Durva in the adjuvant setting versus datopotamab alone, so without immunotherapy, and then again, physician's choice of what to do in this setting. And so again, looking at 8 cycles of an antibody-drug conjugate. So I do suspect that these are going to change how we take care of patients, but I still do think it's important to look at what capecitabine does in this, because not all patients can tolerate 8 cycles of an antibody-drug conjugate after they've had that 5-drug neoadjuvant regimen. So it'll be interesting to see if that might also be an option for patients. So I think real-world data in that space will be helpful and informative. And so moving on to talk about our 2 abstracts that are looking at the management of patients with smaller tumors, so node-negative T1 tumors. I think here are the most recent NCCN guidelines, and what you can see is that obviously for stage 2 and 3, we have a standard of care, but there really aren't robust data about what we should be doing with patients with T1A and T1B triple-negative breast cancers. And so both of these next abstracts are looking at this patient population. So the first was a single institution study done in just under 400 patients. These patients were treated over the course of a couple of decades with adjuvant chemotherapy. And so these patients, you can see here about a sixth of patients who had tumors that were 5 millimeters or smaller received adjuvant chemotherapy. About half of those with T1B and about 2/3 of patients with T1C tumors received adjuvant chemotherapy. And adjuvant chemotherapy did significantly improve overall survival in both the T1B and the T1C node-negative tumors, but there was no significant overall survival. There was a numerical difference, but no significant overall survival in those patients with T1A tumors. So I think reassuring to think that, perhaps we don't need to give these patients chemotherapy. So the next study was a study that looked at the SEER database of patients who were treated over a decade with either neoadjuvant or adjuvant chemotherapy, again, for these node-negative T1A to T1C tumors. Over 8,000 patients had received adjuvant chemotherapy. and about 1,200 patients, sorry, a typo there, had received neoadjuvant chemotherapy. And there were no differences in breast cancer-specific survival with adjuvant versus neoadjuvant chemotherapy for those with T1B and T1C tumors. So I don't know if you all are facing the pressure from surgeons that we've been pushing and pushing to send us these patients for neoadjuvant therapy. And just today I received a note from my surgeon asking me to give a small triple-negative breast cancer patient neoadjuvant therapy. So I'd love to share this data with her. So I think adjuvant chemotherapy, neoadjuvant chemotherapy, these patients do equally as well. And perhaps it's appropriate to take them to surgery first so we don't risk over-treating them and trying to chase that PCR. Because you can see here the PCR rates are very small for T1A's 18%. T1B and T1C in that 40% range, respectively. And I think, are we tempted to want to try to give them capecitabine if they don't attain a PCR? That could be overtreatment because neoadjuvant and adjuvant therapy patients seem to do the best. Neoadjuvant chemotherapy overall was associated with a worse survival as compared to adjuvant therapy, but that was all driven by these T1A tumors. And it's really interesting, I think there were some hypotheses about why these patients don't seem to be doing well. But I think from our first poster, I feel pretty comfortable just not giving these patients therapy at all. It's not going to improve their outcomes. So really interesting pair of posters focused on looking at these small node-negative, triple-negative breast cancers. So next, our next poster from an institution in Brazil was really interesting, and I spent a lot of time reading about neutrophil to lymphocyte ratios and kind of went down that rabbit hole, but was really interesting. This is a high neutrophil to lymphocyte ratio is associated with systemic inflammation. And it's simple. You can just kind of get this information off your CBCs. And there are a number of studies that have shown that patients, regardless of disease, even outside of cancer, those patients who have a high neutrophil to lymphocyte ratio have a poor outcome. And we've seen that with cancer, specifically breast cancer, and we've seen that in response to immunotherapy. And so I just wanted to highlight two studies that I came across. One was a retrospective study in over 5,000 patients with solid malignancies who were treated at Moffitt Cancer Center over the course of 3 decades. And just under 1,000 patients in this cohort had breast cancer, and a high NLR was associated with poor overall survival. This is across tumor types, across different treatments, different types of breast cancer. So very interesting. And then a nice study in stage 4 melanoma out of Memorial suggesting that those patients who have a high neutrophil to lymphocyte ratio do not seem to benefit very much from immunotherapy and have a poorer survival. So really interesting to think about this. So the poster that was presented by Dr. Polho and colleagues looked at a neutrophil to lymphocyte ratio in patients with early stage triple-negative breast cancer. These were stage 2 and 3 TNBCs that were treated with neoadjuvant chemotherapy. The large proportion of these, over 90%, received anthracycline and taxane-based chemotherapy, either AC followed by T or T followed by AC. And what they found was that a high neutrophil to lymphocyte ratio was associated with a lower PCR, poor event-free survival, and poor overall survival. And so it kind of raises this idea of somehow using this in a way to optimize therapy for patients with triple-negative breast cancer. And, perhaps investigating this, it'd be interesting to see in patients treated with the Keynote 522 regimen if it predicts for those patients who may not benefit from IO. Again, is there some other opportunity to enhance efficacy there, but perhaps sparing these patients who may not benefit from IO from all those immune-related adverse events? So I think would be an interesting follow-up study. So I'm going to end with the last study here, which looked at the impact of antibiotic exposure on patients with early-stage triple-negative breast cancer treated with the Keynote 522 regimen. And there are just so many studies out there that have shown us that antibiotic exposures associated with chemotherapy, immunotherapy resistance, worse outcome across many different tumor types, including triple-negative breast cancer. And so just a smattering of studies out there. And so this very nice study presented by Dr. Espinal and colleagues looked at 42 patients who received the Keynote 522 regimen and then categorized them based on whether or not they'd had any antibiotic exposure, either prior to starting their chemoimmunotherapy or during their chemoimmunotherapy, and correlated this with pathological complete response and RCB. And what they found was that, that there was a lower pathological complete response and a higher residual cancer burden in those patients who were treated with antibiotics or had received antibiotics. It wasn't significant, but this was a 42-patient cohort. I'm sorry, there's a typo on my slide. I tried to fix it, but apparently it didn't go through. But I will say that, at least from the literature, there seems to be a suggestion that those patients who got antibiotics prior to chemoimmunotherapy had a poor response in those patients who'd already started it and then went on to get antibiotics. So I think that's certainly something that needs further investigation. But again, you know, I think antibiotics are bad and we should try to avoid them if at all possible in patients receiving chemoimmunotherapy. So just to summarize these 5 really nice abstracts, we know that Keynote 522 is established as the standard of care for stage 2 and 3 triple-negative breast cancer. I think that optimal therapy for residual disease remains to be defined. There are many ongoing trials looking at ADCs, but we've got real-world data with CAPE that in these patients who've received chemotherapy alone, the findings are consistent with the CREATE-X trial. Obviously, it would be very interesting to gather data on patients who got capecitabine after the Keynote 522 regimen, perhaps concurrently with their pembrolizumab, to investigate if that might be an option for patients who may not be candidates for ADCs or may not be able to tolerate ADCs in the adjuvant setting. But I do think that they're likely poised to become that new standard some years from now. Also, in terms of thinking about the management of patients with stage 1 triple-negative breast cancers, these small node negatives, chemotherapy, I think, has been shown now in a handful of studies to improve outcomes for these T1B and T1Cs and could be considered. I think there's really a questionable, if at all, role in these T1A tumors. And adjuvant chemotherapy appears to be equivalent to neoadjuvant chemotherapy, mining that SEER database. And so I think that, you know, maybe there's no push to really try to give these small tumors neoadjuvant chemotherapy. And just to summarize the last couple of things, you know, just that biomarkers remain elusive in the IO sort of area. We saw a very nice late-breaking abstract of the Keynote 522 biomarker data suggesting that there's really no biomarker that helps us predict who are these patients who are going to benefit from IO. It will be interesting to look at neutrophil to lymphocyte ratio and can that be used. And then antibiotic use, again, should be minimized or limited in patients who are receiving immunotherapy. And I'd like to just thank the organizers, Dr. Rugo, and the poster presenters.
Wonderful. Again, another fabulous discussion. So let's, we're open to Q&A, and we already have some in the, from the web. The first question to Dr. Polho, have you tried other cutoffs or evaluated any negative correlation as NLR increases? Like, why does this happen? There's no, it's just on.
Okay, so we did an interim analysis with a small subset of patients in this cohort we presented before, and the cutoff point of something about 1.8 and 2 would give us a good specificity for achieving PCR. And so that's why we chose the cutoff point of 2. Okay. I did not test other cutoff points yet in this cohort of patients, but it's indeed a possible thing to do.
Thank you. Microphone? Introduce yourself.
Thank you. Juan Santamaria, cancer surgeon at University of Nebraska. My question is for Dr. Alexis Espinal. Did you count antibiotics preoperatively, for example, port placement? Some surgeons give preoperative prophylactic antibiotics for port placements, for example. That will be shortly before starting the Keynote 522. And did you count the antibiotic exposure also to be related to surgical prophylaxis for the lumpectomy or the mastectomy? And that's my question.
That's a really good question. We did not count those because almost every patient that we looked at had that exposure. So we excluded that, as we did not count that.
So to piggyback on that, perhaps a single dose of antibiotic given very close to the initial immunotherapy for surgical prophylaxis for port placements could be something to consider about.
Absolutely, thank you.
So what you're saying is that if you had antibiotics before surgery, that since everybody had them, you didn't count them, but it was the extra doses of antibiotics that mattered.
Correct.
And do you think that, I know you looked at this, was there any correlation with getting less treatment because you got antibiotics and so you had an infection, so you missed your treatment, you had a dose reduction, anything like that? Because, you know, that's one of the very nicely done correlation, but it's a little hard not to give antibiotics if somebody has an infection, you know, I mean, a bacterial infection, you know.
Absolutely. I think it's a very difficult decision that we have to make. I would say that the use of antibiotics will help with infection, but at the same time, it has its own risks.
But do you know if it correlated at all with any delayed treatment or dose reductions?
It has.
So could that be the correlate that affected the outcome?
It certainly could. A lot of the patients that we looked at had actually received antibiotics for neutropenic fever and were receiving them for 5 to 7 days at a time.
Right, okay.
And so definitely would
You might
delay
not want to be prophylaxing, but also not to delay treatment is good. So a question that I had and also came up in the chat was to Dr. Anampa. It's a little odd, the T1A tumors. That's not my experience in clinic. And I do give neoadjuvant therapy, particularly if people have BRCA mutations, because they have such a nice response. And you can give them 4 doses of chemo. And then you give them less, you know. So I'm not very anti it, although for T1A, they're really tiny. But so you wouldn't expect people to have such a low PCR rate. So is that because the T1A was determined before you started treatment and you really underestimated the amount of tumor? Or is it that those tumors are very low proliferative triple negative cancers?
So that's a great question. Actually, we struggle with that as well. So to just explain, every patient was categorized based on clinical staging because the neoadjuvant adjuvant has to be categorized in the same fashion. So there's a chance that they could be, categorized wrongly because of that. However, not only they had poor outcomes than T1B and C, but also lower PCR rates. And so that was struggling as well, suggesting that maybe they have some chemo resistance. So maybe small tumors have some senescence or dormancy pathways that could actually lead to some resistance to chemotherapy. But as we said in the other studies, they may not even need chemotherapy.
Right, it may be that, and I just wonder if those tumors have low proliferative sort of LAR type tumors that don't really get PCRs to chemo but have a good outcome. So it's an interesting question to go back and ask. Yeah. Marlene.
Hi, my name is Marlene Kok from the NKI in Amsterdam. Congratulations to all the authors. I think it's highly relevant data that you present here. So I have a question for Dr. Hackbart on the wonderful study of the small tumors with or without chemotherapy. So I was kind of shocked on the overall survival of the no chemo group. It's overall survival, and if you study this in the older population, they probably die from something else. So is the no chemo group older than the chemo group? And, the initiative to collect breast cancer specific survival, I think is also important.
Yeah, I think that's an excellent question and something that we're still working on. I think, as I mentioned to some of you in the crowd, our survival data is death of any cause and not cancer-specific survival. And the median age of our population was 60, and then we followed these patients for over 25 years. And so I think you can imagine patients as they age, they tend to die, unfortunately, of other causes. So I agree with you in that our analysis probably needs further modification to look at disease-specific survival. However, when we looked at those events, disease like progression and things, we had such low number of events, I think kind of speaking to the nature of triple negative, small triple negative, actually, patients tend to do somewhat better. I think it's like an 80% rate where people don't recur. So I agree with you. I think we might need to include either like a bigger population size to actually then get more events because our events were quite low.
And look at the TILs.
Yeah, I agree. Yes, doing things with like histology is hopefully the next step, especially I think in the T1A group to look more at that as well.
That's great. So another question about the adjuvant capecitabine for Dr. Strahan, and there are some in here too as well. The question is, the real-world data for capecitabine is compelling for rescuing non-PCR patients. Should capecitabine be part of a more appropriate control regimen versus ADC? And also with the idea that it's expensive. And I will say that it is part of the control regimen for some of the trials. Some just allow you to choose. I had the question of whether or not you think capecitabine really works and why there was such a small number of people using it when we think of it as a poor but real standard of care.
So I personally can't speak to, as I'm not a treating physician, I'm not a doctor, I can't speak to, my own anecdotal experiences, treating patients. If anybody would like to, chime in with any of their opinions, but just generally for the part where, we saw that only about, 40% of the 660 patients that had residual disease, only about 40% even got adjuvant therapy of any kind. And then when we look further, we see that only about 30% got capecitabine, whether it was alone or with other therapy. So that was a question that a lot of people asked, why at 3 large institutions, why are we not fully utilizing, these resources that we have? And we have the data from CreateX, or even, well, this was a little bit before Keynote, but even then now, so like if we were to evaluate another cohort in the future, hopefully we would see increased usage, but also, we don't have data readily available of reasons why patients didn't get that. So unfortunately, it is kind of an unknown in this situation. We can speculate that, was it provider decision? Was it patient refusal, based on maybe residual toxicity from their neoadjuvant therapy? Was it financial toxicity? So we can speculate about all these different factors that it could have been, why it wasn't, why adjuvant therapy in general wasn't being maybe utilized to the full potential, but we don't have a definitive answer.
Right, of course, and it's that kind of database, very hard to get an answer to that question, but it is fascinating. And I think, Rita, I guess I'll ask you, what do you think about the efficacy of capecitabine in a basal-like residual disease setting? And just to answer the person on the line, it is part of the control for some of the studies. So.
No, I think it's reassuring to see the real world data, because I think a lot of providers might not be offering capecitabine because they feel like it's not effective in triple negative breast cancer after you've had ACT. And so, in that sense, I suspect that may be part of it as well. Although, it's hard to know, it's a retrospective study, a really nice study, but I think it's reassuring, and I definitely think it's worth investigating, just because you'll probably have some people who got it and some people didn't in this Keynote 522 era, and whether that could be an alternative, at least for some patients, to ADCs, which, as you said, are going to be really expensive. But as someone who participates in I-SPY2, it's really hard for people to get ADCs and then Taxol carbo and then AC all pre-surgery. Like, they're exhausted and drained. So I think that's relevant data, even though the landscape is likely going to change.
So let's see, we just have a second left, I think. There were a bunch of questions. I think we talked about the indication for antibiotic use, neutropenia, true sepsis. My understanding from your question was that some people got it just because they were neutropenic. And so generally, given your data, and I think the correlative that was mentioned from melanoma, that one might try and avoid that, unless you had a terrible ANC. And then is the negative correlation between the use of antibiotics and poor outcome related to the reason that led to antibiotic use in the first place? Which
it certainly could be. Definitely a confounding variable. I wonder if we had just looked at antibiotic use prior to the pembrolizumab dose, if that would make a difference. But it's really hard to say, and that's a very good question. That's going to be really hard to delineate in the future.
Of course. And then just lastly, does PCR matter for little tiny triple negative cancers? That was really the point of my question. Is if it's a little tiny tumor and it's a low proliferative tumor, we see these, older women or sometimes young now, I think, with, Ki-67 of 10%, triple negative, 0.4 centimeters. Does it matter?
I mean, for T1A, I don't think PCR or neoadjuvant at all. But for T1B and C, actually, PCR does matter. And the analysis showed that PCR was associated with improved breast cancer-specific survival and overall survival.
Great, thank you. I want to congratulate all of our poster presenters, our excellent discussants, and thank you all for staying for this excellent session.